Thank you so much, everybody who's staying on this late hour. Actually, I think this last talk will wrap up a few things. I have no disclosures. Colonic ischemia after AAA repair actually used to be a common problem, and as Willem showed, it still is a problem, especially after ruptured AAA in patients with preoperative shock and intra-abdominal hypertension, which are the most important risk factors. And Jean-Pierre did some very important research in this field. There are time trends in treating abdominal compartment syndrome. First, we had to recognize the problem. We did that last century. Then we had surgical treatment, decompressive laparotomy. And then we realized we could prevent the condition by permissive hypertension, massive transfusion protocols, early medical treatment, because prevention is, of course, the key to minimize this problem. The consensus definitions and guidelines were published in 2013, and they are still valid. You can read them in intensive care medicine, and there the definition of ACS is important to remind you about, because ACS is defined as a sustained intra-abdominal pressure above 20 millimeters of mercury that is associated with new organ dysfunction or failure. Sustained means at least 2 measurements. So if you have a high measurement, you have to check if the patient is in pain. Pain relief may decrease the intra-abdominal pressure quite a lot. The best is to have an epidural, but also morphine can help. And second, it's not a mere pressure. You have to have some effect on organ function. Anders van Heijnen and we adapted these guidelines to vascular surgery and published a paper in the European Journal in 2014 that may be still of interest to read for those who are interested in this issue. As discussed, not only, of course, the IMPROVE trial, but also the AJAX and EVAR trials showed, as I see it, some advantages with EVAR first strategy on ruptured aneurysms. Even if it's true only for women, it's still an advantage. And the 3-year results from the IMPROVE trial showed effects on quality of life, on cost, and etc. So we feel rather certain that EVAR is first choice for rupture, and many others do too. But when you treat patients with rupture aneurysm with EVAR, most patients are actually treated in local anesthesia, and that was one of the critiques that I made from the IMPROVE trial when I wrote the editorial in the British Medical Journal, that only 1/3 of the patients in the IMPROVE trial were treated with local anesthesia. In Uppsala, we treat about 80% with local anesthesia, and that makes a great difference for the outcome of the patients. They seldom require post-operative treatment in the ICU, but that results in that monitoring the intra-abdominal pressure becomes more problematic. ACS remains a potentially lethal complication. We monitor the intra-abdominal pressure with this Foley manometer method, which was invented in Denmark, and that can be used not only in the ICU, but also in the OR, the high dependency unit, as well as in the normal ward. We just put it between the collector and the urinary catheter. And then you raise it, you open the airlock, and you can easily read the intra-abdominal pressure, which is graded in millimeter mercury. We also did a large cohort study in Sweden using the vascular registry. The first paper was published 2016 in the European Journal, and the second paper, which I will also discuss, is now under revision in the same journal. We included more than 6,000 patients, 20% were ruptures, 80% intact repairs, and at this time period, still the majority of the ruptures were treated with open repair. That is no longer the case in Sweden. Now, you see the incidence is about the same of abdominal compartment syndrome if you use open or EVAR for rupture. Whereas if you do it for intact aneurysm, there's a higher risk with open repair. And if the patient develop abdominal compartment syndrome, they have all these terrible complications, very much more common than if they don't have the abdominal compartment syndrome. And that affects the survival of the patient, which is about half after rupture, and even more affects actually the intact patients. You can see here on the survival curve. And we identified risk factors for ACS. It's the lowest measured blood pressure in rupture, where we can also see that preoperative unconsciousness or using aortic balloon were risk factors to develop ACS. After intact repair, reimplantation of the renal artery was a risk factor. And after both rupture and intact, bleeding above 5 liters. Here you can see this is the second paper that is not yet published, but it was presented as an oral presentation in Valencia. And you see here that there is no difference after rupture in mortality, nor 30, 90 days or 1 year, if the patient undergoes EVAR or open surgery for rupture, if the patient develops ACS. But after intact repair, there's a much higher mortality in patients after EVAR. And we think this is because we don't recognize the problem. Here are also some interesting data showing that there are different reasons why you develop the compartment syndrome. Bleeding occurs early, and EVAR gets compartment syndrome earlier than after open repair. So in conclusion, ladies and gentlemen, although ACS after rupture AAA is less common today as a result of massive transfusion protocols, proactive medical treatment, etc., the consequences are just as serious as before if ACS develops. And ACS is at least as serious after EVAR as after open surgical repair. It develops early after EVAR for rupture AAA, and the diagnosis is often delayed when ACS develops after intact AAA repair after EVAR. So the conclusion is we need to monitor intra-abdominal pressure for about 48 hours after EVAR for rupture AAA, and also in intact repairs if they suffer bleeding complications, such as, for instance, an iliac rupture or something odd happens during a planned EVAR. They should also be monitored for their intra-abdominal pressure. And it has been shown very clearly that you cannot evaluate the intra-abdominal pressure clinically. You must measure it. Thank you.
So any question? Time is late.
I think we are very tired, I suppose, all of us. But thank you for staying on, listening.
So thank you for attending this exciting session.